As a result of overcrowding and the search for ways to manage patients, treatments in the early 20th century were pretty varied and often quite brutal. But we have to keep in mind that the continual return to previously abandoned and brutal treatments wasn't because people were trying to be mean. Instead, it was due to the fact that even as late as the 1930s, very little was known about mental illness, and very few individuals were trained as mental health practitioners. As a result, practitioners were essentially making things up as they went along, trying out various treatments to see what worked. So in the 1930s, some of the treatments that were most frequently used included malarial therapy, in which people would be infected with malaria with the thinking that the high fevers might shock their systems enough to get rid of the mental health symptoms. Deep sleep therapy was also tried, in which large doses of barbiturates, tranquilizers, or sedatives were given to patients, thereby inducing a state of unconsciousness that would be maintained for several weeks. And the idea is that such treatment could rewire a patient's brain and thus cure them for their problems. In the 1930s, we also saw the appearance of electroconvulsive therapy, or ECT, which works by inducing a seizure which has been shown to alter brain chemistry. In the past, this was done without general anesthesia, and the amount of electricity used was pretty severe. As a result, patients often experienced memory loss and broken bones, but now it's done under anesthesia and with muscle relaxants, so it's much, much safer. So today, electroconvulsive therapy is a last line of treatment for severe depression, schizophrenia, mania, and catatonia, and has actually been shown to work wonderfully for a lot of patients for whom medication doesn't work. Also in the 1930s was when we saw the arrival of the lobotomy as a treatment for mental illness. Now, the history of the lobotomy is actually quite interesting. The procedure was originally known as a leucotomy, which was created by Igas Moniz in 1935, for which he won the Nobel Prize for Medicine. Now, Moniz proposed that one way patients suffering from depression in particular could improve was by severing the connections between the thalami and the cortices of the orbital surfaces of the frontal lobes. In order to do this, he would perform a trepanation, right, which is a burrowing of a hole in the skull, and then inject ethanol into the subcortical white matter of the prefrontal area, thereby destroying the connecting fibers. As you can imagine, this was a very delicate, time-consuming procedure that required incredible skill and training from the practicing surgeons. However, because the leucotomy appeared to effectively alter the mental health of patients, great effort was invested into developing a more practical procedure with similar desired results. Walter Freeman, an American neuropsychiatrist, devised such a quick and dirty procedure, which he called the transorbital lobotomy. But the procedure was quite different from what Moniz was doing. So here are the play-by-play instructions for the transorbital lobotomy, and just as a heads up, they're a little bit gross. First, to induce sedation, inflict 2 quick shocks to the head. That would be with electroconvulsive therapy. Step 2, roll back one of the patient's eyelids. Step 3, insert a device 2/3 the size of a pencil under the upper eyelid into the patient's head. Step 4, guided by the markings indicating depth, tap the device with a hammer into the patient's frontal lobe. After the appropriate depth is achieved, manipulate the device back and forth in a swiping motion within the patient's head. To give you a visual of this, it sort of looks like this. I'll pause for a second just to let that sink in. Now, I know that may sound horrendous and frightening and brutal, but let's step back for a second. Now, remember that asylums were overcrowded, and people working in those asylums had no idea how to treat, much less cure their patients. But along comes a procedure that's quick and easy, and that's touted as capable of treating a wide range of conditions, and that does seem to result in a marked behavior change in patients, including the treatment of symptoms of schizophrenia, depression, chronic pain, as well as other mental and physical conditions. So what happens? Freeman becomes known as the traveling lobotomist, performing over 3,000 lobotomies himself and training others, so that between 1949 and 1956, about 50,000 patients were lobotomized. And in some cases, the lobotomies did exactly what they claimed to do. Testimonials from patients said that having lobotomies allowed them to live again, and that they were delighted with the way it turned out. So there were newspaper articles talking about the success of the lobotomy as a treatment. But there were some other really negative outcomes from lobotomies as well. Lobotomies were designed to change people's emotional states, and because of that, it often left people feeling blunted, as well as sapping people's higher reasoning abilities and making them seem there but not there, which led some health professionals to call Freeman's work euthanasia of the mind. So it was sort of a mixed bag of reviews, but the fact remained that it was something that was working for some people. So throughout the 1940s and 1950s, lobotomies and ECT remained the dominant treatments in asylums, in part because, as I said before, client populations continued to rise despite the fact that the numbers of mental health practitioners and caregivers remained stagnant. As a result, one of the priorities of treatment was to keep patients contained, and ECT and lobotomies were certainly one way to do that. Plus, some people said it helped. Unfortunately, particularly in the late 1950s, rumors of abuse and neglect flooded communities who once were proud of their asylums. Thankfully, however, shortly after this point, and when mental health treatment was arguably at its worst, an apparent salvation emerged. And that came in the form of Thorazine. Thorazine, which is the generic name of a drug called chlorpromazine, is an antipsychotic that was used particularly to treat schizophrenia. So this advertisement says, when the patient lashes out against them, referring to hallucinations, Thorazine quickly puts an end to his violent outburst, and then continues to say that at the outset of treatment, Thorazine's combination of antipsychotic and sedative effects provides both emotional and physical calming. As therapy continues, the initial sedative effect gradually disappears, but the antipsychotic effect continues, helping to dispel or modify delusions, hallucinations, and confusion while keeping the patient calm and approachable. And in overcrowded institutions, calm and approachable is exactly what you're going for. Now, although Thorazine was the first medication on the market, it wasn't the only one for long. Because of advances in pharmaceutical technology, in rapid succession, other psychotropic medications became available, making it possible for state institutions to lessen their reliance on ECT and lobotomies, and in the 1960s, return once again to moral modes of treatment. So as we move into the late 20th century, we finally saw a re-emphasis on protecting the human rights of patients, and a new emphasis on individualized treatments instead of group cure-alls. But around the same time, there was also a movement towards deinstitutionalization. So just for some context, in 1960, there were approximately 500,000 patients in American mental institutions. That number dropped to 100,000 by 1986. And that sharp decrease in the number of patients living in institutions was brought about by a few different political efforts. The first was an effort by President Kennedy to decrease the number of people institutionalized. So the Comprehensive Mental Health Bill was passed in 1964, followed by the Medicare and Medicaid Acts of 1966, which in combination provided insurance coverage to the mentally ill, which caused states to greatly restrict long-term full care services in state mental institutions in the late 1960s and early 1970s. Then, in 1972, federal court rulings that said patients could no longer work at mental institutions without pay changed how institutions functioned. Remember that one of the key pieces of moral treatment was that patients contributed to the community, often by doing manual labor. Not saying that's right, but because of this ruling, institutions didn't have enough money to maintain the grounds, and because they were using their funds for upkeep, they also didn't have money to spend on activities for patients that would help them occupy their time. As a result, hospitals started discharging patients and sending them to outpatient treatment in the community. Now, this was a beautiful and necessary plan in a lot of ways, but there were some consequences. One of the main consequences was relocation trauma. In many cases, patients who had lived in institutions for years, if not decades, were released to their families or nursing homes or halfway houses. The problem with this is that those places weren't always prepared to meet the mental health needs of the people who were living in them. As a result, the homeless population soared, and this is still something we're contending with to this day. Despite this, the movement towards deinstitutionalization has persisted, and today, emphasis remains on hospitalization of only the most severe symptoms. Chronic institutionalization is avoided. Emphasis is placed on acclimation into independent living between hospitalization stays, and community-based treatment is most common. Now, I know that is a slew of information, and I would imagine you have lots of thoughts and reactions to what you heard. So you should jot those down, because the first thing we're going to do in class on Monday is to break down into groups so you can talk about your reactions to how mental illness has been viewed throughout history. I'll see you in class.